Thank you all so much for joining us today. My name is Susie Ingwell. I am the CEO of a company called Health Tech Strategies, and I am honored to have Robert Coombs from Baton Health joining us today. And we're going to talk a little bit about the funnest subject in the world, credentialing. Thank you for joining us, Robert.
No, I'm really excited to have this conversation.
I am too. I'm very excited. Let me just give a couple of quick housekeeping items, and then we'll jump right in. So for those of you who are participating, this is set up as a Zoom webinar, which may be different from Zoom meetings that you've attended in the past. If you need to ask myself or our other host, Stan, who you can't see visibly right now, a question, please feel free to type that into the chat. We also have Q&A enabled. So on the bottom of your screen, next to the green share button, there's something called Q&A. You can open that up and put a question in there at any time, and I'll be monitoring those as we go and being able to ask those questions live to Robert. In addition, if you have a question and you'd like to ask that question live, feel free to raise your hand. I believe I can enable your microphone to allow you to ask that question. So there's a lot of different ways that you guys can interact with us today. And then we also are recording this event, so we will make it available for people afterward. If anyone has any questions, please feel free to put that in the chat. But with that, I would love to have Robert introduce himself and tell me a little bit about yourself and how you kind of got into this.
Yeah, no, I appreciate it. So I'm Robert Coombs. I'm the founder and CEO of Baton Health. Have spent the better part of a decade in the credentialing space and originally started with CVOs. So primarily focused on working with payers, very, very high volume of credentialing work. And from the very first days, I remember looking at the workflow and asking questions like, why do we do it this way? And surely there are ways that we can do this more efficiently. Surely the providers themselves are frustrated by this. Shouldn't we be rethinking this? And I just remember getting this sense that people in healthcare had kind of thrown their hands up and said, this is just the way that it's done. So I spent a good bit of time in the CVO space, and then I threw my hands up and I said, you know what, credentialing can't be fixed. This is after being at a CVO that I helped to scale from 200 credentials a month to 25,000 credentials a month.
Wow.
It's after I helped to build a CVO from the ground up that also did licensing and payer enrollment for providers. And ultimately, it wasn't until I had actually spent a little bit of time in the fintech world where I realized actually there are better models here. We is in which we can be regulatorily compliant while also being incredibly efficient for the end users as well as the people in between. And so that's kind of a short version of how we got to Baton.
I love it. And I love, using technology to create good solutions for healthcare. So I'd love for you to just dive in and give us a little bit of background on, tell us about Baton Health. Tell us about who you are. I think you've got a little bit of a slide deck. Feel free to share that.
Yeah, thank you. So the first thing I'm going to say is it's not meant to be controversial, but it should evoke a bit of a reaction. And that is that Baton Health is working to solve the dumbest problem in healthcare. And when I think about the people who are attending today, they may say, whoa, wait a second, you're talking about my job. The reality is the people who do credentialing are incredible. They are often under-resourced. They are tasked with mission critical work that ensures patient safety, but they also often have hand-me-down technology. They don't get to control their own technology agenda. And they are subject to a variety of constraints that come from the regulatory bodies who are sort of setting the standard for what's required, but don't necessarily have control over how they're accessing this data, et cetera. And the result is we just see a lot of inefficiency. I would sort of suggest that this is one of the most antiquated and costly workflows in all of healthcare. And when we think about those costs, it's not just the direct cost of credentialing, it's the knock-on costs of having delayed care, of having providers who are sidelined by delayed credentialing, et cetera. And I think that we can do better. I think we've got good models out there for what that looks like. Um, so at Baton, we actually took a step back and we see a lot of the options that are out there, both in terms of outsourced services and software vendors that are creating workforce workflow solutions, business process outsourcing teams, if you're doing this at big scale. And we just said, what's the one area that just hasn't been solved? Or put differently, where organizations aren't necessarily incentivized to solve it because it's not necessarily the thing that's going to generate a lot of revenue for them. And we decided that primary source verification is kind of the root problem in credentialing. So before go forward, I do want to sort of make sure that people understand when we're talking about credentialing, we're not talking about hospital privileging by itself. We're not talking about payer enrollment by itself. And we're not talking about licensing by itself. We're talking about like the big C credentialing that encompasses all three of these things and more: ongoing monitoring, et cetera, right? Because underlying all of these workflows is the exact same data. And if we think about credentialing, sort of like a background check on a clinician, uh, we have to ask ourselves the question: in what world does it make sense for us to ask the subject of a background check what background we should check, right? And the result is we can see the implications of that backwards process, right? We know that most of these applications start out with errors and omissions. Sometimes we can fix those errors, but often we have to go back to the clinician and ask them to fill in the blanks or correct the errors. It can take months and months to complete this work. And from a revenue perspective, if you're a hospital or a health system or telehealth, right, you're leaving a lot of revenue on the table while you wait for this to be solved. Um, so then you're sort of in a position to ask, well, why is it this way? And this is our best way of visualizing the problem, right? And it doesn't matter whether you are working in the administration of credentialing, right? Your med staff services or front desk staff or a CVO, like there is someone with hands on keyboard uh, trying to query more than 1,000 databases in total, where all of this provider data is fragmented. Or you're actually the clinician and you're gathering all of this information on yourself and trying to keep it all in order, making sure that you remember all those expired licenses, et cetera, so that you can submit that information for those licensing and privileging and payer enrollment events. So we sort of think about this world and we say, what if we were rebuilding this from the ground up today, right? What if we weren't sitting on top of decades old infrastructure, right? What if it wasn't fragmented across more than 1,000 sources? What would it look like? Well, this is where my thinking in fintech sort of came to play a role here. What if credentialing worked a little bit more like a credit check? And this is a discussion I've had with people over the years where like, there are these other models. So we can kind of compare and contrast what our model looks like versus what it looks like in other industries. Um, the current workflow for credentialing starts with a clinician, right? We have them filling out a very, very long application. In many cases, we're talking about 800 to 1,000 pieces of data that we're asking them to fill in. Is it any wonder that there are errors or omissions, right? This is a great way for us to generate carpal tunnel syndrome, either for the clinicians or more likely, they're handing it off to someone else. So this is the very first step where the clinician is now almost pulled out of the process. But the concept starts with the clinician being burdened with telling us all of the information about themselves. What happens if they do omit information? Are we going to find it? Maybe. Um, then we think about what happens when they submit that application. And you have an organization who has to go and verify every single piece of data because we don't actually trust the clinician to give us the accurate information, right? Somehow we're making them responsible for telling us everything that we got to check, but then we have to go and verify those things firsthand, which suggests that like we're just taking it on confidence that they're giving us everything. In fact, we're not. We're telling them you have to swear on your honor that you've told us everything. That's the attestation problem, right? Then you have this redundant workflow. It's repeated time and time and time again by every state licensing agency, every hospital, every health system, every payer, every 2 or 3 years. When we think about all of that work for all of the providers that are either in network or licensed in a state, it's no wonder that this is taking weeks or months to complete because there's a backlog for just about everyone. Now, contrast that with the last time you applied for a credit card or that you went to your bank and asked for like a personal signature loan. They don't ask you for every bank you've ever banked at, or every credit card you've ever had, or every loan you've ever taken, all of your debts and all of your payments. They ask for your social security number. And that is used to ping these credit bureaus who've done the work of federating all of that data from every single financial institution into one place. Now, not all of us love credit bureaus, right? We've got questions, we've got concerns here, right? But think about how much that streamlines the workflow so that you're not filling out a 50-page application every single time you apply for a credit card so that you can get, more airline miles or a discount at Banana Republic, right? That really facilitates the flow of information in ways that doesn't tax the consumer. It doesn't burden the companies that are trying to do these verifications, and it also supports many, many workflows. So not just credit checks, but also background checks by employers. Lots of different things flow from that. And so while I hope that people think more highly of us than some of the credit bureaus, I think that the concept is actually really valuable here. What we could do if we built this kind of infrastructure results in adjudications happening in seconds, not weeks or months. And my vision for this is like, what does the world look like if we were to transition to this? What does it look like for hospitals and health systems and provider groups who currently are spending a lot of time on this? What does it look like for providers themselves who spend an extraordinary amount of time just managing the paperwork, juggling all of these different types of credentialing events? So I'm not going to read through this, but these are sort of the design principles that are embedded in a solution like Baton. We're thinking not how people are doing credentialing today, but how should credentialing be done for the coming decades? How can we save not just a few minutes here or there, or maybe a couple of days off of your credentialing timeline, but how can we save tens of hours per year for every single clinician in the country? How can we save hundreds of millions of hours for the teams that are really responsible for ensuring patient safety and who frankly have better things to do, right? There are all sorts of things where if you had more time, you could actually dig in and be more rigorous with your work rather than being burdened with the back and forth with clinicians. And so this is sort of that enhanced vision for what we showed earlier. It doesn't take the human out of the loop, right? Instead, it empowers med staff services and credentialing teams with instantaneous verification that they know comes directly from primary sources. It fits within the NCQA guidelines, right? It's auditable and it's scalable. So if you're a licensing board and you see all of the brand new licensing applications coming in June and July and August, and you're overwhelmed, nope. All of a sudden, that workflow stays even. And the same thing with hospitals who have, new residents that they're doing credentialing, but they're doing it in batches, and so they generate a backlog when all these new folks come on. Or if you're acquiring a new facility and you have to jam out all of these initial credentialing events, that kind of stuff becomes less of a burden on the teams that are currently doing all of this stuff. So wrapping up the story here, if we think about those problems we raised earlier, right, we can eliminate 100% of the errors that come from manual data entry. Those are the errors that come from providers themselves as they're filling out the applications, but also the errors that come from credentialing teams who are tasked with going out and copying and pasting and copying and pasting data from lots of different sources. Or if you have a software platform who has crawlers, congratulations, you're operating in the modern era. How often do those crawlers fail? How well do they work, not just for physicians, but what about for allied professionals, behavioral health, PT, OT? We built this for the entire healthcare industry. We have everybody under the sun. And the result is a massive reduction in the time spent on primary source verification, a massive reduction in the costs associated with that. And our hope is that we can redeploy all of those resources towards all of the other things that are on your plate that you don't have the time for today. Um, One thing that's a little bit unique about us, we're not a CVO. We don't compete with CVOs. We're also not a credentialing platform per se. We're providing the underlying data that powers all of these workflows. And so when you think about the kind of organizations that work with us, we cover a broad range of healthcare settings, right? We're working with everyone from credentialing teams that are in-house in both like hospital and healthcare settings and telehealth. We're working with associations that represent the providers themselves who are trying to make the lives of those clinicians better as they're going through this workflow, as well as software platforms and data brokers and others who are trying to gather this information so they can streamline these workflows for everybody. So I'll sort of wrap with that. Would love to hear reactions from attendees, and also think a little bit about how this changes not just your workflows, but how does it change the timelines, the economics, the speed to care delivery for the organizations that you're a part of.
This is really helpful, Robert, and I'm excited to dig in deeper. We did have a couple of questions and comments. So one person made a comment that the provider experience is extremely undervalued in the credentialing world. Do you want to speak a little bit more to that?
Yeah, I mean, it's funny because there are a lot of organizations that will say that they're a provider first. And what that means is they're putting the provider first in line, but not necessarily thinking about their experience. And so if you've ever had that experience where, a provider submits their application and then you go and then maybe you discover an old expired license, you have to go back to the provider and say, "Hey, did you mean to leave this out?" And the provider just gets furious. They're like, "First of all, you should know that. And second of all, why does this even matter?" We get frustrated with the providers, right? I talk to credentialing teams all the time and I ask, "What do you think the problem is?" And a lot of them will say, "Well, the problem starts with the provider." I don't think so. I actually think that the problem starts with the fact that we're burdening the provider with work that they didn't go to school for a dozen and a half years to do, right? And then we forget about the fact that they're not just doing it for us, they're doing it for all of our peer organizations. So if a provider has, a handful or a half dozen licenses, they're doing that a few times a year. If they're working in a health system and they got privileges at multiple facilities, they're doing that a few times a year. And then don't get me started on pair enrollment, where they're constantly turning through all of these applications, or their teams are. And heaven forbid they change jobs. Now they got to start all over again, and they may not even be paid the same as what they were until they're able to get through credentialing. So I think if we're really honest about provider experience, we have to create solutions that change the provider experience, right? And it's not as simple as just a credentialing wallet. It has to start by saying we're going to remove them from the burden of being the central source of truth about themselves. One quick last thing that I'll just put out there. If we think about this from first principles, right? How many pieces of data that we use is the provider actually the primary source for? We're asking them again, hundreds and hundreds of fields of information, but at the end of the day, they're really the only primary source for a handful of things. What languages do you speak? What are your practice locations? Are you still accepting new patients? What's your contact information and your fingerprints? Like, there's not much else that the provider is actually the primary source for. They're not the primary source for their education or licenses or boards or sanctions and exclusions, none of that stuff. But we ask them because if we don't, otherwise we have to go on a fishing expedition to 1,000 databases. We just don't have the resources for that.
Yeah, I think that makes a lot of sense. And that kind of brings me to my next question. When you think about the marketplace, I know you talked a little bit about the CVOs and things like that. Who does Baton compare to? This person's really trying to understand what's different about Baton Health or Baton versus traditional credentialing companies.
It's a good question. And we don't really have a great analog. There are some people that are kind of like close neighbors to us. I think about CAQH, right? Who something like 25 years ago came up with the universal application. And that was really meant to make the provider's experience easier because they would just fill out the information once. But again, the premise is it's all self-reported information. And then we're asking for so much information that the provider throws up their hands and they say, I'm going to hand it to my front desk staff or med staff services. And that's where it really starts to go sideways because now you got a lot of hands in the mix. So something like that is kind of an interesting analog to us. The difference is we are exclusively primary source information, right? And so imagine if your CAQH application was all primary source. How would that change the workflow for the providers and for credentialing teams and for payer enrollment teams? I think that's the best analog that's out there. And then in terms of true competitors, the people who we often unseat with these organizations, in a lot of cases, it's BPOs. It's folks who have these huge teams of people, often offshore, whose job is just manual data entry. These are good folks. They're doing really hard work, and the result is very, very error prone and very, very costly because it's so manual.
Yeah, I think that makes a lot of sense. So tell me a little bit more then. So if I'm a health system and I work with a CVO right now, how do you integrate into their workflow? Tell me how that all works.
Yeah, I mean, there are a lot of health systems who have their own internal CVOs.
Okay.
And the way that we would think about this is, this shouldn't change that much in terms of your workflow, right? If your current workflow requires that you take the application and go out and verify these pieces of information, then the question is, how are you going out and verifying them? Are you getting onto a browser and then going out and copying and pasting? Are you getting into a software platform and telling the software platform what license to go out and grab? Or are you using Baton where you can just drop in an NPI and all of that data comes right back out? Remember, this is sort of built like your credit profile, where it just takes a single identifier and all of the information that we have on that clinician comes right out. And so depending on the workflow of med staff services or whoever's doing this, you're essentially just saying, we're going to insert Baton into that step when we do primary source verification. I know that there are some people on the call who are saying, wait a second, that doesn't follow our policies and procedures. Is this NCQA certified? And I'm proud to say we've been working with NCQA from day one. There is no accreditation for data automation. We're working on helping them to build one. But in the meantime, what they've decided is that we're just a technology that allows the primary source data to flow from those primary sources directly to your organization. And so we are not that CVO. We don't displace the CVO. We don't displace your teams. We just automate the data flowing from hundreds and hundreds of sources all into one place for you.
Amazing. Amazing. So can you share with the group like a quick example or maybe a story of how Baton really helped a client solve maybe a credentialing bottleneck or some other issue that they were having with credentialing?
Yeah, so we have an interesting story that is both credentialing and credentialing adjacent. Actually, our very, very first customer was the Cleveland Clinic, but it was for their virtual second opinion program. It's called the Clinic by Cleveland Clinic. And when they came to us, they said, look, we've got a little over, I think, 9,000 people that we need to verify licenses for. Um, can you help us to verify all of the licenses other than Ohio? We said, well, that's interesting. Why don't you want to verify Ohio? And they said, oh, because those are the only licenses that our med staff services are really paying attention to and staying on top of. And it makes sense, right? The Cleveland Clinic, based in Cleveland, four walls, all inside of the state of Ohio. That's their overwhelming focus. The challenge is when all of those providers are put onto a virtual platform. Now, if there's someone in Nashville who wants a second opinion, they have to verify that on the day of that appointment, that provider has an active license in Tennessee. And when the workload was visualized for the med staff services, they said, we don't have the time for this. We're not staffed for this. And so the Clinic by Cleveland Clinic, they sort of came to us And we said, yeah, sure. And they gave us this list of NPIs. And within minutes, we were able to deliver that data back to them. And in fact, now they're getting data every 2 weeks that refreshes all of their license information. We have more behind the scenes. We have DEAs, we have sanctions and exclusions. We have all of this data that can be leveraged. But for the telehealth world, this is kind of a game changer because that's the most frequent PSV that you got to do. And most folks in hospitals and health systems aren't really set up for doing the nationwide licensure monitoring. This is also very, very relevant for folks who've seen the latest NCQA changes that came on July 1st, that transition from monitoring licenses once per credentialing cycle to monthly, right? It's the same sort of tidal wave of work that teams are facing. And what they find with us is they essentially upload a roster of NPIs and they are immediately compliant with those ongoing monitoring requirements. Our implementations take somewhere between 15 minutes and an hour for most organizations. And that really allows them to turn and focus their energy on the other parts of the workflow that are weighing them down.
Perfect. So we have another question in the Q&A. They're assuming that you handle all different types of providers. Is that correct? And then the follow-up question to that is, are you doing anything in the actual provider recruitment end?
That's a, it's a good question. Yes, we do have everyone, and part of this is because when we think about this problem, we're thinking about it again for the scale of the entire industry. So the moment I start working with a hospital, it's not just physicians, it's not just APPs, it's also PT, OT, audiology, behavioral health. It's like everybody under the sun. And it's actually really fun. We start digging into the data. We start seeing these provider types that I didn't even know existed. One that I discovered a little while back is called equine therapists. Right? These are not veterinarians. These are behavioral health therapists, where you can sort of like pet a horse while you're talking about your childhood trauma. I never even knew that they existed until we started looking at all of the different provider types that we have in our data. So today we have about 6.5 million clinicians covering every provider type in every state. And that leads me to this question about recruiting, which is interesting. We originally built this to be thinking about credentialing, so that I could reach in and pull out Dr. Engwall and all of her information in a single query. But then you sort of look at this massive universe of data that we've built, and we say, wait a second, what if we wanted to find everybody who looks like Dr. Engwall? And this is particularly exciting for folks in telehealth, where, if it's a virtual urology clinic, they can reach in and say, show me all of the licensed urologists in the country. And we can display them in descending order of the total number of active state licenses that they have. So rather than hiring someone with 2 or 3 licenses, you can hire someone with 20 or 30 licenses, immediately allowing them to be deployed into a much broader geography, and saving thousands and thousands of dollars on the fees that you would have had to pay to get them licensed up in the first place.
That's amazing. I didn't even think of it from that perspective. So I love that. Tell me how quickly a health system can get up and running with your service.
Yeah, I mean, as I mentioned earlier, our onboarding times are measured in minutes, not months. So it's something that's quite exciting for us because I was recently at the NAMS conference and sitting with someone who was implementing, let's just say, one of the very, very large credentialing platforms. And she said that they had been in implementation for 2 full years, and they were still at least 2 quarters away from being able to deploy this. And during
Wow.
that time, they were paying for their licensing fees, they were paying onboarding fees. In total, there was the better part of $1 million spent on software that they couldn't yet use. And
Oh
it had
my
taken
God.
them hundreds of hours to actually just get the implementation in place. Now, in fairness to that software platform, it does a lot more than we do. But the flip side of that is, what are these people supposed to do in the meantime? It's not saving them any time. It's only adding work for them. And so what we really focused on is, like, how could we get people on board as fast as possible and deliver immediate value while still leaving the opportunity for us to expand the value that we deliver over time? And so today our onboardings basically look like You give us a list of NPIs and you're off to the races. You have a roster that is monitoring all the licenses and sanctions and exclusions, DEA, et cetera, so that you can just take that work off of your plate. There are still edge cases where there are pieces of information that don't quite fit. You have databases that go down from time to time. Today, we're experiencing an AWS outage, and we've seen some of the primary sources actually go down, which means in many cases we have more data than the primary source does.
Mm.
Um, but at the end of the day, like our focus is really on operational efficiency. And remember, I've now had hundreds of people with a title of credentialing specialist or credentialing agent who are doing this work, and these are the people who like I think of, and like the 8 to 10 hours a day of manual data entry that these folks are doing. I'm just saying, like, how can we actually change them and deploy those people at the top of their skill set rather than just having them doing this like mind-numbing manual data entry?
Yeah, it makes total sense. We've got another great question in the chat. So our participant says, I saw the demo for state licensure verification on your website. What other types of primary resource verifications do you offer? And is there a way to view all of the PSV demos in one place, or could you perhaps even showcase them to us now?
Yes. So the quick answer is we are behind. We've been doing some development. We've been moving very, very quickly, and as a result, we haven't really done a lot of these like videos that demonstrate like what we can do. So we need to update that. We need to be able to showcase things a little bit better. Um, I pulled up some of these screens ahead of time because of the AWS outage, just to make sure that we didn't have any problems with connectivity. But this is essentially what the platform looks like today. So you have um, the licenses that we're pulling from every single state, and we started with licensure, so we put that front and center because that's generally the thing that people are doing the most of. But this is just the first type of data that we verify. So here you can see we're pulling in a few million licenses from California and a couple million from Washington. We look at some other big states, a couple million in Texas, a few million in Florida. But then when we think about smaller states, it's still a lot of data that's coming from these, right? Almost a million licenses in Colorado, a little over 500,000 in Kansas. Illinois sneaks in with a couple million. So you think about it, and the current workflow is a provider tells us, 3 or 4 or 5 or 10 states that they have licenses in, and then we have to go out to each one of these databases individually. And so our thinking is different. And actually, I'm just going to grab an NPI here. We'll do it live and see if the internet is participating. Our sense is rather than going in to each individual state one by one, what if you could just gather everything all at once? So you see how fast that happened. That's how quickly our database works. Because we've already gathered all of this information, we're refreshing it. Our average data freshness is 7 days, and it's straight from primary sources. But the beauty of it is it's all standardized into a single schema. So nobody's doing like the internal mental translation of like, oh, in this state they call it this, but it actually means that to us, et cetera. And what's great is for each one of these licenses, you can see all of the information that you need for that individual credential. You can go straight to the detail page. And now we can see even more information on this individual license. And if we want, straight to the source. So a single click takes us right to the primary source. This is the Florida database directly, right? And so our hope is that you can leverage the data that we've gathered and standardized for you. But if there's something that's missing, or if you need to see it with your own human eyes, you're one click away. And so when we do that across an entire provider, you can see all of the states that a provider is licensed in. We can see all of their license information, right? This is each of those licenses, including the old expired licenses. Turns out, some states have a hard time resolving temp licenses or telemedicine licenses, compact licenses. We've got them all. And we can also go through, I'll just go back to this provider. We can see DEA licenses. We can see sanctions and exclusions. This one's free and clear. And we can also do individual verifications. I haven't done a verification on this provider, but if I were to verify this provider, and this means that I've got a verification log that is a snapshot in time of exactly what that provider's primary source verification looked like. So again, this meets NCQA standards, et cetera. This is here's an example. We've got a provider who's got a bunch of DEA licenses. We're updating this data daily, and the result is there are some organizations will that will essentially like hot swap their DEAs, right? If you're right on a state border and someone's practicing in one state on Monday and Tuesday and another state on Thursday and Friday, they'll swap them out. We're checking that daily, and so we can see the latest updates on where those DEAs are assigned. And then this is what it looks like if you're doing this across an entire roster. So this is a roster of a little over 8,000 providers. And for each provider, we're showing the active licenses, the licenses that are expiring soon, and then the old expired licenses. And so the credentialers in the house are going to say, oh, okay, well, that's the totality of data that I need if I'm doing a credentialing event. But other folks will say, well, I don't actually care about those old expired licenses. And so for them, we say, all right, well, let's just keep an eye on those active licenses, right? So whether you're thinking about someone who's practicing in a brick and mortar or on a telehealth basis, right? If it's telehealth, this is essentially your inventory. This is all of the states where a provider can be deployed. And for each of them, remember, we can go in and see all of the individual states. So that's pretty helpful. And then one other feature that we built, this is when we started working with someone who was responsible for maintaining licensure. And her problem was when a license is expiring, she has to go and touch that license almost once a week for 4 to 8 weeks to see, has it been renewed yet? Has it been renewed yet? Has it been renewed yet? And she's also back and forth with the provider saying, have you submitted your application, right? What this does is it allows you to say, show me all the licenses expiring in the next 90 days or the next 60 days or the next 30 days. And these are standing reports where you don't have to click on a single license. You can just see the latest status on it. And what's beautiful about this is you can sort of reach out and say, hey, Dr. Thaker, your Indiana license is about to expire. Dr. Sartan, your Indiana license is about to expire. You can actually do personalized outreach to these providers and let them know where they stand. And when it starts getting closer to like 7 days from expiration, you can reach out and say, just a heads up, we're starting to take you off this schedule because we're concerned you're not going to be compliant when the day rolls around. So that's a quick behind the scenes of what the application looks like. I didn't get into the recruiting platform. That's pretty exciting. But at the end of the day, we're really excited to meet our clients where they're at. And we're confident that we've got the data and some of the reporting that can work right into your workflows.
Love that. Love that. So we have another great question in the chat. How do you handle states or provider types that are behind a paywall? How does that work for you guys?
Yeah, it's tricky, and this is one of the things where I think that the fragmentation in the industry has made it very, very difficult for organizations who have a broad variety of provider types or who are covering a lot of states, because it really forces you to do it one by one by one by one. The reality is, if you're building this for a single organization, it is tough to justify the expenses of going out and buying that data in bulk, or spending the time to work with the primary source directly so you can get like a data sharing agreement. For us, it's different. It's all that we do. And so in cases where you have to purchase data, we purchase data. We do whatever we can to ensure that we have the latest regulatorily compliant data on a consistent basis. And so sometimes that means that we're actually purchasing the data set in bulk, even if we're not necessarily providing credentialing data on all of those providers.
Makes sense, makes sense. So speaking of kind of the economics, let's my favorite three-letter acronym ROI. Let's talk a little bit about ROI. What kind of savings can customers of yours expect to see? Do you have any examples of those?
Yeah, I mean, it really depends on what your current workflow is and the scale of the organization, how many people you have. The way that I think about it, like I sort of think about the unit economics of the system and say, all right, how many people or how many task hours do we spend each month just on primary source verification? How many task hours are spent by the clinicians filling out this information? And then how much goes into just verifying that the data is up to date? So if you're already buying some of that data, you add that to the price tag. If you've got a handful of people that are doing this work, add that to the price tag. And then you can kind of get to a sense of like what the price tag is for your organization. We've worked with organizations that have, one person who's managing this for 100 providers. And we've worked with organizations who have 30 or 40 people who are managing this for 10,000 providers. At the end of the day, we want to be able to just remove the manual data entry from the workflow. So if that's taking up 20% of your time because you got a very efficient team, that's more or less what the task savings are going to be. And then when we look at our pricing, we're built like a utility. So you just pay for what you get. There isn't like a $250,000 annual licensing fee like there is for a lot of the big credentialing platforms. If you've got less than 10 providers, the data is free. We don't even want you to spend money on this. We just want to make your jobs easier. If you're showing up with a smaller group of providers for anywhere from 10 to $60 per provider per year, you have ongoing monitoring in a turnkey fashion. And when we start looking at the larger organization who have thousands and thousands or tens of thousands of providers, it really does start to come down to dollars or even cents per verification. Um, the beauty of what we've built is it scales to any size, and I don't know that we've ever lost on price. I think that the people that we work with are really much more focused on how they can integrate it directly into their workflow. Um, and that's where the challenges often arise. Do you actually have an existing contract that you can't get out of? Do you have engineers that require the data to go in a certain pathway, and so they need to work with an API? The good news there, we're API first. So anything that you can do in the web application, you can do directly in the API. And so engineers love us because in a handful of hours or a couple of days, they can have a direct integration into our data set.
I love that. So tell me about a little bit more about that. If I'm a health system or hospital and I want to start using you tomorrow, what kinds of things are needed on the client side to ensure like a smooth onboarding into what you're doing?
Yeah, I mean, I think the best opportunities for us come with someone who knows that this is a challenge for them, and so they kind of have a sense of how much time this is taking. And the reason we like that is because we have something to go by where we can sort of show them exactly what's being saved, regardless whether you have that or not. We generally just will ingest a roster. If you send us that list of NPIs, we create the roster and you're up and running. If you send us the NPIs with some of the information you have, like the licenses you know about, et cetera, we can also actually do sort of a quick audit for you and show you how much of your data was right or up to date, how many new licenses that you didn't even know about exist for those providers. And we can then use that as an opportunity to start to determine like how much time is going to be saved over the course of the coming year. In many cases, the time that's saved is already spent in someone's mind because they're like, once I'm done with this, I'll have more time to do this other stuff that's on my plate.
I love that. I think that's fantastic. I love the whole audit thing. I didn't even know you could do that audit thing. That's fantastic. See, I'm even learning something today, and I know you guys. So that's fantastic. I don't see any other questions in the Q&A, but if anybody has any, please feel free to add some. I think from my perspective, I'd love to know where you see Baton Health going over the next 12 to 18 months.
Yeah, I mean, in many ways, what we're building is like kind of the unsexy infrastructure behind credentialing. And so when we think about that, what we're really working to build out is essentially a complete and compliant credentialing application on every single clinician in the country. And so you heard me talk earlier about the data types that we have. We don't have all of them, right? The 13 or so different data types that are required for a complete credentialing event. We're working our way up to that. And when we have that, this data object that we've built, we call this the baton. Every piece of data in this data object is being updated on a daily, weekly, and monthly basis. And so if you can imagine, once that's totally complete, just kind of like your credit report,
Yeah.
once that's totally complete, then we can just overlay business logic on top of it, and we have real-time credentialing. That's what we're working on right now. We're engaging with some health systems to be the first in the country that are going to have this real-time credentialing. They think it's exciting because it enhances the provider experience. I think that it's exciting because they'll essentially be able to look at the entire industry and see who's effectively pre-credentialed. And what's neat about this model is that business logic that I talked about overlaying. It can be NCQA, Joint Commission, URAC. It can be something that's specific to your organization where you say, actually, we have slightly different or higher standards than the regulatory agencies that come prepackaged here. What this really does is it frees people up to have the kind of flexibility in their credentialing workflows that they always wanted without having to pay a tax on time or errors or costs.
Perfect. So speaking of regulatory, now I will not get political here, but the regulatory and payer environments continue to evolve. So how do you foresee that, or do you see it impacting you in the way that you support hospitals?
I mean, I'm not going to say that I don't think that it's going to impact us because the second I say that, I'm just going to get walloped by some big policy change. But the way that I think about it is the data is the data,
Yeah,
right? I don't think that there are going to be massive policy changes that come down and say, okay, you no longer have to view licenses, or you now have to view some other type of data that's never been contemplated in a credentialing scheme before. Instead, the changes that we see are more subtle, but they often have a bigger impact on the teams that are doing this, right? So I mentioned it earlier, that NCQA policy shift, right? If you're doing license verifications or monitoring once every credentialing cycle, or even once every year, and then it goes to a monthly event, your workflow just increased by like 24 to 36 times for that one data type. And so even though it seems sensible, like if we check a license in January, don't we also want to make sure it's good in February or March or April?
I think.
The implications of that are massive. And Baton is really built to make that a negligible distinction. I don't care if you have to check licenses once a month or once a week or once a day. We're building the infrastructure that enables that sort of like near real time and soon real time monitoring to be in place so that you can both scale up the frequency that you're checking these things, but also scale up the different types of data that you're looking at, right? And maybe we want to be doing the same kind of monitoring on DEA licenses that we want to be doing on licenses. All of that is possible, but only when you bring all of that data into one place and make sure that it's all updated on a daily, weekly, or monthly basis.
So I guess my last question for you then is we talked a little bit about the impacts to the people doing the work, the impacts to the providers. I'm sure probably everybody on this call who's familiar with this space understands how this impacts patient care. But that is the one thing that, really why we all work in healthcare innovation. We want to see new products get to market. So, especially with these new rules that have come out, and now you've got this larger process they're going to have to do more frequently. How do you see that impacting patient care? And, when you guys come into the mix, it sounds like it would be negligible. So I'd love to hear a little bit about that.
Well, look, at the end of the day, I think that patient care is something that everybody in credentialing cares about. And in fact, it's the thing that keeps them up at night. People who do credentialing are often, they've got the night sweats thinking, what if I missed something, right? What if the next doctor death is in my network or in my hospital, and there's something that I could have done to prevent that? And I think it's really unfortunate because these folks are so dedicated, and yet they're sort of like carrying the burden of that. And it's what makes them so rigorous about doing this work and making sure that they're checking as frequently as they can and getting it right and all this stuff. The problem is that the devil's in the details. And so it forces them to get closer and closer and closer to manual data entry, as opposed to being able to take a step back and look at the big picture, or try to work with clinicians who maybe do have a mark on their record, but it's something that shouldn't necessarily result in them losing their career over. If only they had someone who's going to partner with them and make sure that that they're able to sort of like get back on track. So, um, I am not the expert on how we ensure um, quality of care, right? What I know is the people who do this work are the experts, and we're just sort of burdening them with all of this distracting workflow, as opposed to allowing them to go in and really dig deeper when they see a flag. So my hope is that this would actually like increase indirectly. We're not increasing the quality of care or safety, patient safety, but indirectly, my hope is that organizations will actually have more resources to dedicate towards the work that allow them to see those bad actors when they come up. This is interesting. I had a conversation yesterday with a clinician who looked at what we were doing, and he said, "I'm not sure I like this." I said, "Well, why not?" And he said, "Because if I'm getting sued, if I have these lawsuits against me, and I don't want people to know about them, you're just going to tell it. You're not going to take my word for it. You're just going to tell these people about them." And I said, "Yes, that's exactly right. You may not like that your credit bureau is telling your bank that you went bankrupt in the
Yeah.
last 2 or 3 years, but don't we all feel safer knowing that our banks aren't built upon the risk that would be borne if they're just sort of like giving out loans and credit cards willy-nilly to people who can't afford them or who've had problems in the past and who can affect all of us, really, right? If you're a vendor and you're taking someone's credit for granted, like you may not be getting paid, or we become dependent on this sort of like house of cards. And so, um, you know, I think that if you're a bad actor, this is probably not good news. I think bad actors actually flourish where data is fragmented because it allows them to kind of like um, you know fall through the cracks,
Yeah.
and we're pasting those cracks up.
I think that's great. And somebody made a comment too that quality and safe patient care start with credentialing. So I think that kind of reinforces everything that you just said. Next steps: how do people get a hold of you if they want to learn more? How do they learn more? How do you how do they work with you?
Well, I think that we'll be reaching out with a follow-up to attendees. The easiest way to get a hold of us is to just go to our website or reach out to me. I'm Robert at batonhealth.com. Um, but find us on LinkedIn or on our website, batonhealth.com, and we're doing demos all day, every day. We're meeting with organizations of all stripes. So that's probably the easiest way to find us, and otherwise you'll also see us at conferences, NAMS and NCQA, et cetera. We're trying to do our best to get close to the people who are really the experts in the work, and those are the medical staff professionals that do this all day, every day.
Love it, love it. Thank you so much for your time today, and thanks to everybody who joined us today. We will have a copy of this webinar available here probably within 24 hours. So if you'd like a copy of it, please let me know. But if there's nothing else, we'll wrap up for the day. Thank you so much.
And thank you to everyone who attended, and thank you for the work that you do. From the bottom of my heart, I think that this is some of the most important work in healthcare. We just go about it in a real hard way.
Love it, love it. Great way to wrap it up. Thanks, everybody. Have a great day.